So hi guys, I am Ishika. I'm an IMT1 doctor. I work in Hull at the moment. Um, you can ask me more questions later. So obviously, just a couple of things. Housekeeping. I cannot see you guys while I present, so I cannot see if you guys type in the in the chat box. So if I've asked a question, please just unmute and answer. There are no wrong answers. Well, there are no wrong answers, but you're learning, so it's okay if they're wrong. Okay, cool. Can someone unmute? Make sure that your mics are working. Are you guys there? No?
Hello. Yeah.
Yeah. Okay. So I can still hear you. And we've got about 39 slides. I had 37 slides. Hopefully we get through them. Excuse me, quite quickly, and you guys can go on with your Monday evenings. Okay, stop me. Okay, yeah, you can raise your hand. Oh, well, I can see that you're raising your hand now because I've got the screen open on the side. But once I start pressing PowerPoint, I will not be able to. So, whoever's raised your hand, do you want to unmute and say something? No. Omar, can you keep a track of who's raising their hand and see if it needs to be done immediately? Because I
Yeah,
won't be able to see it. Yeah.
yeah, that's fine, no worries.
Okay, that's fine. Okay, so let's make a start. So I'm told that you guys are a mixed bag of students, first to final year or second to final year students. So I've tried to sort of cater the talk to keeping it such that everyone gets something out of it. If you're a initial year, first or second year, all you need to know is even if you take away two things from the talk, I'd be very happy. Later year students, if you're able to feel even a little bit more confident to read a chest x-ray, I would be happy after this. Okay, so let's make a start. What is a chest x-ray? Okay, so basically a chest x-ray is what we call it's a quick image that you take off the chest. It's an x-ray, so you're basically irradiating small amounts of radiation to see an imaging technique that will visualize your chest cavity, which has your heart, your lungs, the airways, your bony structures, of the upper part of your arms, your chest, and sometimes you can even see the spine on it. But one thing to remember when you're looking at an X-ray, any X-ray, not just chest X-rays, they are basically two-dimensional structures. It's a two-dimensional view of a three-dimensional structure. So a lot of times you probably wouldn't be able to tell the depth of certain things. So they're not the end-all, be-all of investigations. We've got loads of investigations that come after this. But as far as an initial quick-fire investigation goes, this would be, it gives you a lot of information to manage your patients. Okay. Let's look at let's look at the normal anatomy on a chest x-ray. We will break down each of these words for you in the coming slides. So this is a normal x-ray. I've just picked up one that's labeled so that you guys can see the difference between that one where there's nothing labeled, and if you're new to looking at it, it will look like you don't know what you're seeing. So just as a basic rule, what you see, so the black bits are air, the white bits are bone, and as the tissue gets denser, the more whiter it is, or the more lighter it is. So it's all radiology, and radiology is playing in shades of gray. So you can see trachea, carina, bronchi, they're all they've all got air, they're all air filled structures. So you can see the trachea over there, it comes down. Sometimes in some people you'll be able to see the bronchi, you can see the bifurcation, and you can see the lungs, which are filled with air, so you'll see black bits. Everything else is the tissues are denser, so the heart's got blood. The bones are obviously the densest of them, so you'll see them as the whitest things on the X-ray, and everything else will be in different shades of gray based on how dense they are compared to bone, and compared to water. So why do we use chest X-rays? Now would be a great time for people to start. You can just unmute and answer.
It could be used as a diagnostic tool or a hallmark for maybe in cases of people suffering from pneumonia or COPDs.
Excellent. So diagnosis. What else can you do with an X-ray?
You can kind of assess whether or not like a pacemaker or a device has come out of its original positioning.
I will take that, but it's not why we do an X-ray. You can see pacemakers on X-rays. You can see the leads of the pacemakers on the X-ray, but it's very difficult to actually see if it, unless it's grossly, kind of, if there's something that's supposed to go into the right ventricle and the lead is somewhere else altogether, then yeah, you can say, but usually not something you do to see the exact positioning of leads in a pacemaker. But you make a good point. We can see if patients have pacemakers. Next. What else can you do with X-rays?
Could we also monitor some conditions that some patients actually have?
Excellent. Yes, you can monitor patients. What kind of conditions would you monitor with chest X-rays?
So some genetic conditions like Ehlers-Danlos syndrome, or when there's the I think the sinuses of Valsalva, or you could also do it with cystic fibrosis patients.
Unlikely. Like anything cardiac, there are lots of, like, you wouldn't monitor them with chest X-rays. They are not those are not what you'd monitor. They're all good points, but they're not the X-rays, not the modality. Chest X-rays are not the modality that will monitor them. What we would monitor would be, say, somebody who came into hospital with a nasty, gunky-looking pneumonia. You gave them 2 weeks of antibiotics, or a week's worth of antibiotics. But usually the X-ray findings of pneumonias after antibiotics will stay the same. So if you want to monitor whether the consolidation or the pneumonia has resolved, you would repeat an X-ray on them. Okay? Other things that you do with X-rays, you can see if people, not just chest X-rays, you can monitor people's fractures, you can monitor heart failure, fluid status, all of those things can be monitored with chest X-rays. Okay. Similarly, follow-up comes under the same umbrella of monitoring patients. Okay? So let's just move on to what are the different things that you'd see when you're looking at a chest X-ray, when you start with looking at a chest X-ray. How many of these terms are familiar to you guys? None? One, two? In the context of chest X-rays, of course, like I'm sure you guys know the meanings of them. Okay. Does anybody want to hazard a guess at what is rotation in a chest X-ray? There is no such thing as a stupid answer, so go for it. If you guys are typing or you're putting your hands up, I can't see.
Oh, sorry. It might be the rotation would be to measure the distance between the two medial edges.
Medial edges of what?
Of the clavicle.
Okay.
I think.
Yeah. So, very good point. So if you look at this X-ray, and you basically, when you're looking at somebody's X-ray, you're already, like I said at the start, your body is a 3-dimensional structure, yeah? and the X-ray is giving you a snapshot of, it's basically squashing your chest cavity into a paper thin film and telling you that this is what your chest cavity looks like. So you can't say but if you're sort of rotated to one side, some things will look bigger than they're supposed to, some things will look smaller than they're supposed to. So you might think that it is an incorrect, you'll feel like, oh my God, somebody's got cardiomegaly, without actually realizing that they're probably slightly rotated. So how would you check for rotation? If you look at the X-ray over here, I've got it marked. You've got two clavicles on the X-ray. You've got the spinous processes. If the distance between the medial edge of the clavicle and the spinous process is the same on both sides, then you can say that the X-ray is not rotated. If the distance is more on one side, then it means the X-ray is rotated, and you will not be able to gauge anything like deviation of trachea. You will not be able to gauge mediastinal shifts because they will all be skewed. Yeah? Okay. Next one. Inspiration. What is inspiration in the context of a chest X-ray?
Is that assessing the adequacy of like the lung fields? So like whether the patient has taken a deep enough breath?
Yes. So basically, when a film is taken at inspiration, your lungs are filled with air. And you obviously, if you look at any X-ray, you need that kind of contrast of air to the air is the darkest thing you will see. So if you don't have contrast, so if you look at the film on the right, that's an expiratory film. So you've actually whooshed out the air from your chest cavity. So the lungs are smaller than you'd like them to be. Over here, in this the film on the left side is an inspiratory film, so your lungs are actually full, so you can actually see the rest of the lungs as well. If the parts of the lungs are not aerated, you will not be able to see that bit, so you can't compare anything. So usually we would prefer patients to have an inspiratory film. And how would you know whether it's an inspiratory or an expiratory film?
Do you count the number of ribs you can see?
Yeah, very good. Do you know what numbers anteriorly and posteriorly are you looking for?
I'm not entirely sure, but is it 8 anterior ribs?
No, so it's 6 anterior ribs and 10 posterior ribs in the black bits. So like the black lung field. Can you guys see my cursor?
Yes.
Oh, that's the wrong thing. Laser. Yeah, so you see the black bits over here and see the black bits over here. You can count more ribs over here than you can count over here. So it'll be an ideal inspiratory film. You should be able to count 10 ribs posteriorly and 6 ribs anteriorly. This isn't something you need to know off the bat. It comes with experience. You don't have to sit and count every time. And don't worry about it. It's just for you to know that if I had to look at this film in a patient who was unwell and I didn't think I thought it was an inspiratory film, I'd wonder why they've got volume loss on both sides. So it becomes important at that point to know whether the patient actually had a full breath or they did not have a full breath. Okay? That's the significance of it. What do you understand by the word projection of X-ray? No. Okay. So this projection, there can be basically, it's the type of view of an X-ray. So there can be PA views, there can be AP views, which are the ones that we use very commonly, especially when it comes to a chest X-ray context. So PA views, PA is postero-anterior view. So if you look at the image of this guy here getting his X-ray done, the direction in which the rays are passing is the direction that you'd call the X-ray. So that's the source of the X-ray, and you put the film on the patient's anterior chest wall and they're getting irradiated from the back. So that is the film, the beams are going from the posterior to the anterior, so that makes it a postero-anterior X-ray. So this is a posterior-anterior X-ray in which you can, these are the ones that you want. If a patient is well enough to go and stand in front of the X-ray, in the X-ray room, they don't come, it's not a portable. If they're able to stand in front of a tube and get that X-ray, that is the most ideal one that we'd want because it has the least amount of distortions. You'd be able to, like, these are the optimal views for chest, lungs, for soft tissues, and for the cardiac shadows. The way to differentiate between a PA view and an AP view is by looking at where the scapula is. So if you look on this X-ray, the scapula is over there and it's not impinging on your lung field. So sometimes if you look, there'll be a scapula that's here or here. That is not a PA view. That would become an AP view. So if you see the scapular borders are outside the lung field, that would make it a PA view. An AP view is what you'd see patients having on the ward, or if they are too unwell to stand. ICUs, wards, emergency X-rays, when they're done on trolleys, are AP view X-rays. In a pinch, they will give us a diagnostic. So going back, so basically in this, where the image is labeled as film is where you put the cassette, and here you're irradiating from the front, that becomes an anteroposterior view. This view, if you wanted to purposely do it, you do it for visualizing the spine and the bony cage. But here you'll see that the scapula is floating around in the middle of the lung field. I don't know if you can see it's here. That is the scapula. That is the scapula. It's in the lung field, so you can say that this is an AP X-ray. Are we all okay till here?
Could you just outline where the scapula is again, please?
Yeah, let me draw it for you. So it's that thing there and that thing there. Can you see the really faint white shadow in the back?
Yes, thank you.
Yeah, but if you look at this X-ray, you can't see said white shadow because it's sat there. Yeah?
Thank you.
The last view is a lateral view. They look like that. I've just put this here for you to see how it looks. It gives you sort of like a different angle, but we very rarely use them anymore because they're not very useful. If we want such a view, we would just CT scan the patient. Okay? What do you think is exposure of an X-ray? Anyone?
Is it like how much safe radiation someone can kind of receive?
Good try, but no. So X-rays are very negligible amounts of radiation. They're not great. We wouldn't want to be putting pregnant women through X-rays, but they're not. We can put people through multiple X-rays and it would still be safe. So no, it's not that bad. Good try. So basically, penetration is, how X-rays are black and white. If you over penetrate an X-ray, it can be too white, which is an underexposed X-ray, where you can see the cardiac shadow. It looks a bit fluffy, and everything looks more like white, bony. Overexposed, which is everything is more black. So again, can you see on both of these images, different structures look hazy and distorted, so you can't really see much about what you want to look at. Like if I wanted to look at this X-ray for a pneumonia, I would be squinting really hard at it because you can't see anything that is conclusively going to tell you anything about them. So they're both over and underexposed X-rays. So when you look at the one on the left side, it's underexposed. Basically, it's too white, and it means that the radiation has not gotten through the body adequately. So it looks more like bone than it's supposed to. And the X-ray on your right side is an overexposed X-ray, which is basically there is too much radiation that has gone through, and it looks more like air rather than anything else. So the way to differentiate it is, one way is obviously to look at this white and black, and you can say, okay, it's not what I want to see. Or you can look at, this is a normally exposed X-ray, the third one, is you should be able to see the spinous processes, but just not like, if you look at the overexposed X-ray, you can actually see the spaces. So you can see, you can literally draw the spines here. Yeah, you can delineate each spine over there, but over here you can't delineate them, but you can say that the spine is there, which basically means that you should be able to see the spines, but only if you squint really hard at them. Unlike being able to see them really clearly. If you can see them really clearly on a PA X-ray, it means that your X-ray is overexposed. Okay? This is not something that we do to the patients. It's something that the radiologist will do. And usually now with digital X-rays, they tend to be quite good with manipulating the exposure of an X-ray. So again, something for you to, I know as medical students, when you have to present what an X-ray looks like, they're expected out of you to say whether the X-ray is adequately exposed or not, which is why I've put it in. But in clinical practice, you can always muddle and play with the X-ray settings on digital X-rays. So move on to the fun part of it. We've done the theory. So you now look at, how do you approach interpreting an X-ray? So there's lots of ways to do it. There's no one way is the best way. I'm going to go along the ABCDE approach because it is something that you learn quite a lot in practice, and it is used quite a lot in practice. So we're just going to go with ABCDE. Does anybody want to expand ABCDE for me?
Is A referring to airway, so like
Yeah.
tracheal deviation?
Just tell me airway. Tell me what ABCDE is, and we'll go on the context of the X-ray. I'll explain it.
So A is airway, like trachea. B is lung fields.
Okay.
C is cardiac borders. D is for diaphragm, and E for everything else.
Excellent. So A is for airway. You're looking at the trachea. Can you see the trachea here? Yeah?
Yep.
You can see that's the carina. That's where it's bifurcating into the bronchus. You can see this actually quite clearly. Yeah? B is for breathing. Pleura and lungs. We will go over how pleura and how lungs look on pathological X-rays, but in a physiological normal X-ray, you can see that you can see the lung fields, and you can't really delineate pleura from it. Okay. C is circulation, which is the cardiac shadow. You can see the left bar, that's the aortic knuckle, and you come down, that's the left border of the heart. The right border is just hanging on behind the sternum. You can see it peeking out from the side. Okay. Diaphragm, you all know, diaphragm separates the thorax and the abdomen. The right diaphragm is usually slightly above the left diaphragm. If it's at the same level, you might want to consider whether there is something going on over there. Not always, but keep it in your mind that there can be something going on there. And E would be everything else, so that would be your bony cage and the soft tissues. Does anyone want to tell me any other approach they've been taught about reading chest X-rays? Is that no, we've not been taught anything else, or okay, so the other ways to do it is if you read it from inside to outside or outside to inside. Like I said, there's no wrong way of doing it, as long as you've looked at everything you're supposed to be looking at. Okay? So let's go on to common pathologies. The initial few X-rays where I'm only going to show you what the pathology is, it will be an X-ray. So you can unmute and tell me what you think it is. And if you get it right, I will just explain it. If you don't know what it is, I will still explain it. Okay. Any takers?
Maybe a pneumonia,
Okay, what makes you say that?
because of the right lower zone of pacification.
Excellent. How would this patient clinically present to you? Typically.
Shortness of breath, cough, fever.
Excellent. So yes, you are perfectly correct. That is a consolidation in the right lower lobe. It's opacification, it's white. There is an air bronchogram, which is basically all the white bits that you're seeing are fluid that's collecting in the lung and making it look gunky and yucky, which is what is the pneumonia over there. Patients would normally present with fever, productive cough, shortness of breath, any of those things. Okay, so excellent, pneumonia. Next one. Any takers?
Tension pneumothorax.
I haven't given you, I will take that answer, but I'll be very wary of calling something a tension pneumo when you don't have history. Okay, but I will take it. It is a pneumothorax, so this would be, you can see on the left lung, you can see an airway here, that's the trachea. You can see that it's deviating towards that side. Yeah, everyone's still with me? It's not coming down straight, so it's slightly deviated. And the lung field, you cannot see any markings in this area over here, which basically means that that's all air without any bronchovascular markings. So that would mean that this is the pleural edge, that's the pleural edge, and the rest of it is air. So air in the pleural cavity is a pneumothorax. Pneumothorax, can somebody tell me why somebody would have a pneumothorax? Why somebody would have a tension pneumothorax? It's beyond the purview of this lecture. But people can have pneumothoraces because it can be primary, it can be secondary. Management depends on what you do. A tension pneumothorax usually requires somebody to have air that's coming out one way and you're basically sucking air in but not pushing it out. So tension pneumos usually have a history of trauma associated with them. So I would, if you were given this x-ray in an exam, or if you looked at this x-ray without any context, I would stick to calling it just a pneumothorax to start with. Okay?
Sorry, I had a question on this.
Yeah?
What's going on the right side?
So good question. Sometimes what happens, basically, this person, they've only got one lung to work with because their other lung is not doing anything. So one, it can either be that they've got a diseased lung on the other side. Two, it can be that they've got some fibrotic changes in the background that's doing it. Or it can just be an underpenetrated X-ray.
So is that like normal? Does it normally look like
Again,
that?
depends on what they've come in with in terms of, it could be normal for them. So, which is why when we're looking at X-rays in a clinical setting, we prefer to compare it to what they've had, what previous X-rays they've had. So if I looked at this X-ray in a person who had no previous imaging, they looked horrendously short of breath, I'd probably deal with the pneumothorax first and then repeat the X-ray and see what's going on there. Say if they were fluid overloaded, then this could be things like fluid in the chest as well, like pulmonary edema. It could also be just background changes. So a lot of it depends on how people clinically present to you. X-rays are not, you need to interpret X-rays in clinical context, not in isolation to what's happening over there.
So it could be like anything, basically.
It could be anything,
Yeah.
yeah. Basically, obviously there are certain things that we can tell you that this is what it looks like, but a lot of times when you go through X-rays, it will be what did the patient present with? Are they symptomatic for it? What can you hear on that side of the lung? So if this person had, say, fine crepitations, I'd probably say, oh, have they got some background interstitial pulmonary disease or any pulmonary fibrosis? Or if they had coarse crackles, then you'd wonder about whether they've got fluid on that side of the lung. So if they're perfectly asymptomatic, you could just say it's fine. There's nothing there. Yeah?
Yeah, great. Thank you.
Yeah. Okay. Next one.
Pleural effusion.
Why are you calling it a pleural effusion?
Because one, there's like a blunting of the costophrenic angle on the left
Mhm.
side. Yeah, and is that a meniscus? I don't know.
That is a meniscus. Yes, that's what I wanted to know. So basically, if you go by, again, your A to E assessment, trachea is deviated. You can see it moving that way. So your mediastinum has shifted. So the upper mediastinum has shifted. The cardiac shadow is there. And you've looked at this lung field and you've told me that it's white and there is a meniscus sign. So that's fluid. All of that's fluid. There is supposed to be an angle here, which is, you can't see that angle. So very rightly said, blunting of said angle. And when you've got fluid, your lower mediastinum, so your cardiac shadow, has also been pushed that way, which means there is extra volume on this side, which is pushing it there. So A, pushing it, B, you've seen, C, cardiac shadow moved. So this is perfectly right, pleural effusion. Okay? Are we all
We
clear?
just got a question in the chat
Yeah.
on how do you spot a costophrenic blunt?
Okay, so look at this angle here. You can see the angle. It's sharp. Yeah? Where is the angle here? There isn't. You can't even see it. So there is no, this would be here, would be then the costophrenic. This is costo. There is no phrenic there, because if that was your lung, then there is no angle here on the diaphragm. So there is blunting. I think I might have a different X-ray where I can show you what just blunting looks like, but this is very clearly completely whited out there. So that's complete fluid. So you can say that there is no angle there. So that's blunted angle. Yeah?
I was just wondering,
Mhm.
because it's unilateral, would you therefore suspect like it's more of a lung pathology than anything systemic?
Good question. Yes, I would probably go with the idea that it's more to do with the lung, more to do with lung unilateral pathology, but it can happen. So if somebody's got, say, a left-sided breast cancer, it can be part of a metastatic disease over there. Sometimes people have ovarian cancers, which can cause issues on the right side or on the left side based on where the cancer is. So yeah, but if it was one-sided effusion, clinicians are more likely to put a needle into it to get fluid out. But if you had, say, like a bilateral small effusion, you'd probably wait and say, oh, is it heart failure? Is it, is it heart failure, basically, if they've got generalized effusions. But yeah, unilateral can be local, but always remember that there could be like systemic issues as well, like cancers.
Okay, thank you.
Okay, sometimes unilateral effusion. So if you've got like if the liver is irritated on the right side, so the liver is basically sat here, right? That would be your liver below the right hemidiaphragm. So if the liver is irritated, there can be a transudative effusion just on that side. It's technically not a local lung issue, but it's a liver issue that's causing a lung issue. So there's a lot of things that can cause effusions. You'll learn that as you go and see more and more patients. So wouldn't worry about that. But good question, good point raised. Unilateral effusions usually point towards something local, something more problematic. Bilateral effusions usually to do with things like heart failure and stuff, fluid overload, anasarca. Okay.
Yep, thank you.
Also, just to remember that people can have bilateral effusions because they've got bilateral pneumonias, bilateral pleural effusions with cancers, bilateral issues with lung cancers. So don't run off or don't write off every bilateral effusion as a heart failure effusion. Okay, but keep it in your mind that it can be both of those things. Ooh. Why has that happened? Oh, yeah. So this was, how do you remove these things? Erase all ink. Okay. So I know somebody asked me about bilateral effusions. No, this is not bilateral either. Do you remember how you said the thing about the meniscus sign? This one doesn't have a meniscus sign. Does anybody want to guess why?
Could it be inside the lung itself?
Unlikely. So basically, the effusion has been curtailed on this place because the lung has the middle lobe there on the right side. So it's the fissure that's coming here, and then below that is the lower lobe of the lung. So sometimes it can get crossed off over there and say like there can be fluid in the fissure and an effusion. So in those kind of cases, it's still an effusion. It's just been curtailed in that place at that moment without the meniscus sign and makes it look flat. The other time that it can be flat, if it's a flat surface over there, is if there is air and fluid in the pleural space. So a hydropneumothorax can cause a flat and not a meniscus. Just for you guys to remember that just even if it's flat and you've got white bits at the bottom, it can still be an effusion. It's more likely to be an effusion. It is more likely to be an effusion. They don't always have the meniscus sign. Okay? When else would you not see a meniscus sign in effusions? Do you guys know what loculated effusions are? So anybody want to take a guess at loculations? Okay, so basically, the pleural space, you normally have about 5 to 10 mils of fluid in the pleural space. If you've now got something like an empyema or something that's quite sticky and forming an abscess over there, you can have fibrin threads that form in the pleural space and sort of loculate your effusion. So there'll just be like a blob over there. Like it can even just come out over here and be like an air fluid level there, and say that there's fluid here and air there in the pleural space. So if you've got an empyema or something that's causing a locule over there, that can also have a localized effusion, but without the meniscus sign. Okay, so just remember, the point to take away from that was that all effusions need not have meniscus sign. Don't write it off just because it doesn't have a meniscus sign. Okay. Take a guess. Anyone? Do you want to start reading the X-ray? You don't have to give me a diagnosis, just start reading the X-ray.
The trachea is deviated a little bit towards the right. Can you see that? Could we assume that there's a deviation there?
There is a very small deviation. I will take that, but no, that's not what we're looking at here.
Looks like cardiomegaly, maybe.
Cardiomegaly, very good.
Heart failure.
Heart failure. Okay. Why would you say heart failure?
Just because maybe there's, I don't know if that's like curvy V lines on the sides.
B lines, yes. Very, very well done. So the X-ray has cardiomegaly. That heart looks massive. And you can see these curly B lines. What are curly B lines? What? Okay, I don't want to know what curly B lines are. Well, I've written the answer on the screen as well. That was a stupid question. So basically, this patient, you can see how the X-ray looks generally quite hazy, but it's well exposed because you can just about see the spines. But the X-ray still continues to look a bit hazy. All the vascular markings look a bit more prominent. The bronchovascular markings look a bit more prominent. Basically, is that the lung is waterlogged, or the lung, all the bronchovascular bundles have fluid in their walls, which is what is making it look more white than black. Curly B lines are just these lines that are coming out from the bottom here, and they signify pulmonary edema. And the cardiomegaly we have discussed. Okay? Heart failure. Just to touch upon cardiomegaly and how you would look at quantifying cardiomegaly, you need to look at a PA film more than an AP film, because in an AP film, there will be apparent cardiomegaly. So I wouldn't be quick to judge an AP film for cardiomegaly. But if you drop a perpendicular line through the center of the X-ray, which runs along the spinous processes, and then drop a line from that central line that you've passed to from the hilum of your lung to, I don't know how to explain this. So basically, maximum curvature of the heart. If you look over here, if you drop a line from here, and then at the maximum curvature there, and at the maximum curvature here, that A and B, and then between the two costophrenic angles would be C. So A plus B, if divided by C, if it's more than 50%, then you can call it cardiomegaly on a PA film. And if it's more than 59% on an AP film, you can call it cardiomegaly. You will learn how to eyeball this as you see many X-rays, but that is just the theory behind it. Okay? Okay. New X-ray. Any takers? Okay, so basically, this is an X-ray. It's quite common. It's quite common finding that you'll see in a lot of X-rays when you're working on, say, surgical wards. Basically, you can see that there is some amount of volume loss on both sides. So it seems like it's a poor inspiratory film. The right hemidiaphragm is much more elevated than the left, but they both are quite high. So it's atelectasis or volume loss, lung collapse. Your patient is not breathing well enough after surgery. They will collapse the bottom lobes of their lung because they're not getting aerated very well. And that will cause atelectasis. Now, this atelectasis, you'll see lots of people looking at this X-ray and saying, or somebody who's got linear atelectasis, basically fibrotic branding or volume loss, and say maybe it's a pneumonia. Again, all of it comes in clinical context of what we're doing. Okay?
Sorry, which bit looks like atelectasis?
Both sides.
So it's the hemidiaphragm's elevation.
If you look at that bit, that's a fibrotic band there, that one. And both, like if you start counting the ribs, you'll see that it seems like an expiratory film rather than an inspiratory film. Ignore the orange arrow. I don't know why it showed up there. I think it was because I took a different X-ray from somewhere else. But if you look at the lung fields, they look like they are an expiratory film, but it's not an expiratory film. This is an inspiratory film. It's because when patients have abdominal surgery or chest surgery, moving their chest wall to breathe deep, to have a good inspiration, hurts them. So they will start breathing shallow. When you breathe shallow, you don't aerate the lower parts of your lungs very well, which means all the alveoli over there will collapse, causing volume loss in that place. So it's more on the right side than it's on the left side in this case, which is why the trachea seems to have moved a little bit as well. But there is volume loss on both sides. Not something that we would expect. It's not most of the time. It just needs people. You just need to tell your patients to breathe a little bit more. You ask them, you give them breathing exercises and chest physiotherapy, and they improve quite well with it. So it's just to sort of introduce you to the term atelectasis and what it can look like on an X-ray.
Oh, thanks. Do you know what that thing in the left diaphragm, that hole over there?
This?
Yeah, what's that?
Do you want to tell me what that is? Does anybody else want to hazard a guess at what that is?
Stomach gas bubble.
That's the stomach gastric bubble. Very good. So your stomach basically your esophagus is coming here, and then you've got the stomach there. So all the air in your stomach is going, obviously air is lighter than fluid, so it'll go on top. So that's the normal gastric bubble. Sometimes you can see even a duodenal bubble. That's probably the colon, but if you see it somewhere here, you can even see sometimes they have a duodenal bubble. Okay?
Oh, okay. Thank
Normal
you.
finding. Gas, air, there's usually gas in your tummy.
Sorry, could you explain what the fibrotic bands were again, please?
So, okay, let me just wipe this thing again. So, do you see these?
Yeah.
Yeah. So there are some fibrotic bands that sometimes people can have fibrotic bands which will pull sort of your airways closed. Okay, let's actually, if this is confusing you, let's go back to this basic then. There's two kinds that can happen. Lung can collapse when you're not breathing well enough, like I explained, when your alveoli are collapsed because you're not breathing in enough. That's one kind of atelectasis. The other kind is when you've got fibrotic bands, like in this person, they've got these fibrotic bands which are pulling the lung tissue and forcing them closed, which is what's going on here. Does that make sense now?
Yeah. So is that like a separate pathology?
So it can be, it's not usually, it usually comes along with other things. So people who've had, say, previous issues in their lung, they could have had surgery, or they could have had lung surgery, or they could have had like a lung abscess or empyemas, which can cause inflammation, and then they can have fibrosis in that place. Or they could just have idiopathic pulmonary fibrosis, which eventually can lead to collapses in the lung because they're not breathing enough.
That makes sense. Thank you.
Yeah. Okay, we're just going to go quickly over these red flag x-rays, and then I'm a bit conscious that we're losing a lot of time. So I'm not going to ask you these ones. So we've already discussed pneumothoraxes. Like I said, they are basically when you've got patients who come in with trauma, or they're gasping for breath and they've got a flail segment. You'll see people having tension pneumos. Over here, you can see that there are no bronchovascular markings in this whole place. The lung is collapsed into a ball at the hilum. All of that's air, that's the lung. So this would be a pneumothorax. I also said it would be a history-related diagnosis. You can see the other bits that I've explained on the previous pneumothorax x-ray, where the trachea is deviating this way. The heart has moved that way as well. Basically causing a upper and lower mediastinal shift because there's too much air. Tension pneumothorax is will definitely push your mediastinum, because they're forcing more air into your chest cavity but not actually releasing any out. So it's like a valve that's been formed which is pulling air in but not pushing it out. So obviously the heart needs space to pump, it needs space to exist. You can't reduce the space, so it'll start moving to the other side, which gets picked up on the x-ray as mediastinal shifts. You need to treat it immediately. Everybody needs to know how to treat these. They're basically, you jam a needle into the second intercostal space to decompress. Anybody want to hazard a guess at what this is? 10 seconds. Okay, that is a pleural effusion. It is a massive pleural effusion. The whole thing is white. So the whole of the right lung has been covered by fluid. You can say that it's an effusion because, again, there is too much volume in that place, which is pushing the trachea that way, and the heart is almost completely onto the right, into the right, shadowing it on the right lung. So that would be a massive pleural effusion. These kind of patients would need you to put a drain into their chest to drain the fluid out. Okay, any questions? No. Okay. This would be, if you look at this x-ray, look at that one, that you can see the upper mediastinum here, that's the heart. Now look at this one, where that is the upper part. What I showed you earlier was just a tube, is very wide here. This is a widened upper mediastinum, superior mediastinal widening, which can happen in aortic dissection, mediastinal hematomas. These patients usually don't get x-rays to start with. They usually come in quite sick, so they end up going through the CT scanner. So you'd very rarely pick this up. If you're going to find a widened mediastinum on an x-ray, then you might be looking at something else, such as a lymphoma or a thymus tumor. All of them are things that occur in the upper mediastinum, which will present with a widened mediastinum. Okay. I want to know what you guys think of this x-ray. Anyone? Does anyone want to look below the diaphragm? No?
Is that like a herniation of the diaphragm? I don't know.
No. Good try, but no. So that is air under the diaphragm. You should not have air under the diaphragm. The black bit over there should not exist. Yeah, that bit over there shouldn't exist. So that's air under the diaphragm. It is due to a perforation. Bowel perforations can cause air under the diaphragm. It is an emergency. Please do not sit on these patients. Call the surgeons. Get them a CT scan, see where they've perfed, and then they need surgery. Okay? Case scenarios. I don't know if someone's typed something in the chat because I cannot see.
Yeah, we've got a question. Steph, if you'd like to unmute. I don't know. I think you should just carry on.
Okay.
Steph, if you want to ask a question, just type it in the chat.
If you type it in the chat, I'll respond to them after I'm done with the case scenarios. We've got about 4 cases that we can discuss, and then we'll be done. Okay, so we're just going to breeze through them. Your first scenario is a 50-year-old patient who's come with sudden onset chest pain and shortness of breath. What would you diagnose if you looked at that x-ray?
A pneumothorax.
A pneumothorax, very good. How would you manage this patient?
Needle decompression.
Okay, so if it's a tension pneumothorax, you would do a needle decompression. If I told you it was a spontaneous pneumothorax and they've got such a huge one, then we would, very right, pneumothorax, we would needle decompress them, and then we could put a chest drain with an underwater seal. This is another X-ray showing a pneumothorax. If you just going forward, if you see the second X-ray that you see would be the same diagnosis as the first one. It's just another X-ray, so I can expose you to a bit more X-rays than just looking at the same X-rays over and over again. Okay, so please don't get confused because of that. Are we all on the same page? Pneumothorax, needle decompression, chest drains. Okay. Next patient is a 65-year-old lady who's presented with progressive shortness of breath for a few years, has a chronic cough, dry cough. She's a 40-pack-year smoking history. What do you see on the X-ray? What is your diagnosis and management?
Feels like the chest is hyperinflated. Could be
Hyperinflated,
COPD.
very well, very good. What else do you see? What do you think of the heart?
The cardiac window is reduced.
Yeah. So basically, you are absolutely right. Hyperinflated lung fields and the cardiac shadow looks very tiny. What do you want to diagnose this as?
COPD.
COPD. Just to preface, COPD is not a diagnosis. You stand like, if you told a patient that they've got COPD based off an X-ray, you probably would get clobbered by the respiratory physicians. But this is what a COPD X-ray does look like. But COPD is diagnosed with pulmonary function tests. So please do not diagnose people based on their X-rays. Okay?
Why is there a small cardiac shadow in COPD?
Because your lungs are expanded to the point where they're squashing your cardiac shadow. So your heart is basically moved slightly backwards. And remember that this is a 2-dimensional view of a 3-dimensional structure. So in that shadowing, your lung is coming in front of the heart. Your lung, basically, the lung fields have expanded to the point that they're going to come right in front of the heart. And that will cause what you call a tubular heart. The heart is normally sized in most of these people, unless they've got end-stage disease with heart failure and right heart failure and things like that. They've usually got normal hearts. It's just the X-ray that makes it look like a tubular heart because you're looking at it in 2-dimension.
Okay, thank you.
Okay, so this is just another X-ray, and I remember somebody asked me about what blunting of CP angles looks like. This is what it looks like. Can you appreciate that now? They're not sharp angles. They need to be sharp angles. This is what blunting looks like. Very subtle blunting. So this person's probably got small effusions, very, very small effusions. You couldn't tap them, but that's what blunting would look like. Okay. So very nicely done. Hyperinflation, flattened diaphragms. Your diaphragm normally would look something like that. It looks flat here because your lungs are hyperinflated, tubular heart. Diagnosis is chronic lung disease, COPD, and what would you do to treat them? You ask them to stop smoking, bronchodilators, steroids, and oxygen therapy. Next question. Are we all okay with the previous COPD X-rays? Any issues? No. Okay. Case scenario 3, you've got a 50-year-old lady who presents to you with cough, rhinitis, generalized malaise, and fever spikes. What do you see on the X-ray?
Bilateral hydrolymphadenopathy.
No.
Heart failure?
Sorry?
Heart failure?
Unlikely, no. What would you diagnose this as? Ignore the X-ray, what would you diagnose this as? It's winter. If you're, whoever said that, no. Okay, that X-ray is a perfectly normal X-ray. Yeah, in somebody who's come in with cough, rhinitis, generalized malaise, and fever spikes, it could very well just be a viral infection. The X-ray is normal, also a normal X-ray. You have to remember, don't look for things to be wrong in your patient's X-rays. Always know that about at least 50 to 60% of X-rays that you're going to see are going to be normal X-rays. You do routine X-rays for people as baseline investigations for people. So always, always, always have at the back of your head that the X-ray could just be normal. Okay? And a lot of people in winter have viral infections. Viral infections, unless they're very severe and in very immunocompromised people, will cause shadowing in your X-rays. But majority of them are normal. So high index of suspicion, but for a normal X-ray, please. Last case scenario. This is something I've just added so you guys can have a look at something that we normally wouldn't see on an X-ray. So it's just for your knowledge and for me to feel a bit happy about myself. 70-year-old lady who presents with hemoptysis, lost weight, and poor appetite. What are you looking at on the chest X-ray?
Cannonball with metastases.
Cannonball
Yeah,
metastases.
carcinoma.
Very, very well done. Another X-ray showing cannonball metastases, lung secondaries. And you would, obviously, if you look at something like this, you want to scan them to see where the primary cancer is. This particular person had a primary lung cancer, which you can see there. Okay. But you'd normally want to do a CT scan of the chest, abdomen, pelvis. If they're torrentially bleeding, then you have to control the bleeding, so support their bleeding risk, clotting risk, and treat the primary cancer. Okay. So in summary, we have learned the ABCDE approach to looking at X-rays. Again, if you're not comfortable with that, you can devise your own way to look at them. As long as you cover everything, how you do it doesn't matter. Recognize normal anatomy, recognize that X-rays can be normal. Majority of X-rays you are looking at will be normal, even if patients are symptomatic for certain things. But at the same time, know what common things look like in pathologies, on X-rays, and always, always, always correlate your X-ray findings with the clinical findings, and identify and know what red flags look like on X-rays, and always ask for help if you feel like you're in too deep. Okay? That is things that you can look at. Radiopedia has some excellent X-rays for you to look at. Life in the Fast Lane explains a lot of X-rays. I quite like how they explain X-rays, so if you guys are interested in further reading. But that being said, chest X-rays are going to be your bread and butter from when you become F1 doctors. So I wouldn't worry too much about it. You will learn by experience. This is one thing that you will not have to skimp out on. You will not skimp out on, and life will force you to be good at them. Okay.